Hello dear viewers, in continuation of this series on antibiotic selection for difficult to treat or resistant organism, in this video I am going to discuss about Stenotrophomonas maltophilia infection. In the last part of this video, there are few questions related to this presentation which you can attempt as per your convenience. I am Dr. Sunil Garg and welcome to Essentials of Acute Care. There are various challenges in treating Stenotrophomonas infection as we discussed in my last video with crab infection, and these challenges occurs both when therapy is given empirically and also once the organism is identified. In terms of empiric therapy, the commonly used empiric therapy for various infections are generally not active against this organism. Therefore, this organism remains uncovered in empiric therapy most of the time. Hence, it is important to consider this organism after considering various parameters, and it includes previous culture results if available, clinical presentation of patient, individual host risk factor like duration of hospitalization, any use of broad spectrum antibiotics recently, local prevalence of this organism, and whether patient is immunosuppressed or has chronic disease. Challenges even remains once the organism is identified. It often remains unclear whether the organism is simply a colonizer or a true pathogen, especially if it is recovered from the non-sterile site. Even if it is a true pathogen, this organism has resistance to multiple and the broad-spectrum antibiotics, hence difficult to treat. There is also a problem with lack of the standard of the care antibiotic regime for this organism, so effectiveness of other regimes cannot be evaluated appropriately. Also, there is a problem with antibiotic sensitivity testing for this organism. The general treatment approach for this organism is similar to general treatment approach for the crab infection in terms of combination therapy. Although the preferential therapy for the crab infection include the use of ampicillin sulbactam, it is trimethoprim sulfamethoxazole for the Stenotrophomonas maltophilia infection. The combination includes the use of two antibiotics in combination out of trimethoprim sulfamethoxazole, tetracycline derivative which includes minocycline or tigecycline, cefiderocol and levofloxacin. The combination of ceftazidime avibactam with aztreonam can be given to those patients who are critically ill due to this infection or when the preferential therapy cannot be given. Trimethoprim sulfamethoxazole is preferential therapy and given with another antibiotic which include tetracycline derivative, cefiderocol or levofloxacin, and it is given as a part of combination therapy. Dose range of this antibiotic is 8 to 12 mg per kg of trimethoprim component in 3 to 4 divided dosage per day. Tetracycline derivatives, which includes minocycline and tigecycline, are also preferential therapy, and out of these two antibiotics, high-dose minocycline is preferred over tigecycline. These antibiotics are not suggested for UTI infection due to this organism. The dose of minocycline is 200 mg intravenously or orally every 12 hourly. In terms of other antibiotics, cefiderocol is also a preferential therapy as the trimethoprim sulfamethoxazole and tetracycline derivative. Cefiderocol is given in combination with another antibiotics at least until clinical improvement is observed. Here it is important to note that levofloxacin is not a preferential therapy. Additionally, ceftazidime alone or in combination with avibactam is not suggested for this infection as avibactam is unlikely to expand the activity of ceftazidime against this organism in the absence of aztreonam. It means whenever ceftazidime avibactam is given to these patients, it should be given in combination with aztreonam. To summarize the management of Stenotrophomonas maltophilia infection, cover this organism in empiric therapy in appropriate clinical setting based on your local data. Differentiate between colonizer and the true pathogen. Check sensitivity data and use combination therapy out of trimethoprim sulfamethoxazole, tetracycline derivative, levofloxacin and cefiderocol. Ceftazidime alone or in combination with avibactam is not suggested for this infection, and if the patient is critically ill, use ceftazidime avibactam in combination with aztreonam. Here are few questions. You can read questions and its choices and discuss with me. You can write your answers in comment section box where I will respond to your answers. You can pause the video and read questions. Thanks for watching this video and please do not forget to subscribe to this channel. I would appreciate your feedback and suggestion, and bye for now.